So I think that that's a really important beginning to all this to kind of go over the history behind the medical treatment we've been providing, how it's helping people live fuller lives for much longer, and how much that's affecting the primary care that we are able now to provide for these patients, and the services we're able to provide for them. And I also think that understanding how important like empathy and empathetic interaction with patients is, to get them feeling comfortable and engaged in their own care is so important because really regular follow-up and just regular treatment really provides so much to patients living with HIV. And I think that that's just a really beautiful backdrop for going into some information I think is maybe a little more black and white and dare I say a little more boring. Um, but really important in providing the care and the services that people need. So I'm going to go over some information about primary care, looking mostly at the 2024 IDSA guidelines came out in August this last year. And like we've been saying, and I think that Dr. Dworak really hit on, is like much of the care we provide in primary care is no different than it is anywhere else. There are some differences and there's some unique aspects, and I will try to highlight some of that. But just being a good provider and a good advocate and a good medical provider and whatever your role is the mainstay of what we do. I put this in there. This is a little busy, but I have something like this that I 100% stole from some of the other wonderful providers at the SCC clinic. And it's just kind of helps remind me of a lot of the things that I want to keep in mind. There's a lot to do, and I think there is a lot of primary care when it comes to kind of some of the screenings that we're doing and immunizations is kind of very similar to what it's like with other individuals, but plus, plus, plus. There's sometimes a couple other things that we really want to keep our eyes on. And so having a checklist like this that I keep at least at the end of my annual visits or even every note helps keep track of the things that what's next. Hey, would you mind doing one or two more boosters of vaccines you need? Or hey, there's another screening test. We talked about it last time. Would you mind doing it this time? So there's a lot for patients to do and keep track of. And I think sometimes just trying to throw everything at once sometimes is quite a bit. And something like this really helps keep track of things so that we can continue to chip away at things as we see them over the years. Um, so one of the main points I want to make that a lot of guidelines and this point will come up a lot in talking about providing care for patients living with HIV, especially over the long term, is that most deaths in patients receiving antiretroviral therapy and getting really regular care are not related to age-related illnesses or opportunistic infections, and that the HIV infections themselves increase the risk of cardiovascular disease, renal disease, liver disease, malignant diseases, and that these diseases happen at younger ages and in the general population. But in the context of people getting really good care and having a well suppressed viral load, people are living well into later age, into their 70s, 80s, and beyond. And a lot of these other things are coming up even more often than in our other patients at those similar ages. So I think that's something to really keep in mind. So again, I'm going to try to summarize some things over the next 15 to 20 minutes so that we can have some time to discuss. But these are the guidelines that I'm really kind of pulling pretty much everything from. I think one of the main things that I want to get across is that engagement and adherence is so important to get to that viral suppression that's going to lead to the lower risk of opportunistic infections, and is going to lead to people living those long, full lives, and also give us all the opportunity to provide all of that, all of this primary care. But it's really important to talk about decreasing barriers to care, providing linguistically and culturally appropriate care, ready access to interpreters, really giving some thought to culturally competent care, gender affirming and trauma informed care is incredibly important, as I think Dr. Dworak really highlighted in that last case. Addressing structural and social determinants of health in many different ways, and there's lots of different ways to do that, but keeping those things in mind so that we can help patients with those things so they can make sure that they're getting in, and we can take a close look at all of the specific medical needs that they have. And I feel like at the risk of kind of tooting my own horn a little bit, it's really important to identify a primary care doctor, a primary care provider for patients, so that they're having someone that's really going to coordinate a lot of these primary care needs, um, in addition to their very specific needs in regards to treating HIV. There's a lot of long-term monitoring that needs to be done. There is a whole section in the guidelines that goes over kind of what we do when we first diagnose someone. I didn't want to go into that because I wanted more time to talk about when you're seeing someone over the long term, what are all the things you've got to remember, year in and year out, as far as screening for certain things and monitoring for certain adverse effects. But if you do get to see someone pretty close to their diagnosis, remember that rechecking an HIV RNA within 8 weeks, and every 8 weeks until viral suppression, then every 3 months to ensure maintenance of suppression. You can lengthen that out if things are really going really, really well. Just remembering that if you are ordering those viral loads, that little blips or an RNA that's detectable but less than 200 can happen. And just before thinking about, that this is a failure of therapy, talk about adherence. How often are they taking things? Are they tolerating their meds? Are they having side effects that's leading to missed doses? And are they having any interactions with their medications? So again, I think, then being connected to a pharmacist or someone that can help you really dig into that and make sure there's not any little interaction or anything that you're missing that could explain these things to make sure they're getting the best care that they can. Um, that a CD4 count every 3 to 6 months, for 2 years, if not virally suppressed. But once the CD4 rises to greater than 500, really one of the big things that we're watching over the long term is that viral load. And then have an idea in your mind about when to think about HIV genotyping. I lean a lot on my colleagues when I have questions about this. If you're, if and consider retesting if you have virologic failure, if antiretroviral therapy has been initiated, has the initiation's been substantially delayed, definitely repeat testing. But I asked some of my other providers if they have any concerns about genotyping and when it's right. But that's something to keep in mind. There's a lot of blood work we do in patients, checking their blood counts, I get a lot of complete metabolic panels, but very specifically every 6 months to a year, checking their glucose, their creatinine and GFR electrolytes, AST and ALT, and bilirubin, at least a couple months after ART initiation or anytime they change, but also just every 6 months is pretty reasonable. Consider a yearly urinalysis. Remember that you're going to be regularly screening for tuberculosis and hepatitis C, hepatitis B, especially when you start. And those at increased risk, it's actually reasonable to screen more often. Um, and then we'll talk more about talking to patients that are able to become pregnant about their if they intend to get pregnant, and talking about how that works with their medications, their viral suppression, how important that is, and also doing regular pregnancy testing as indicated, but definitely prior to starting antiretroviral therapy and anytime it's changing. And we'll talk more about STI screening specifically later. There's a whole section on mental health and substance use, and I think the biggest thing here is to make sure that you have a plan in place to screen for at least depression, but also probably anxiety every year. Mental health burden in patients living with HIV is higher than the standard population, and so screening is really important. I mentioned earlier about trauma-informed care and being comfortable having, talking to patients about potentially very traumatic events. Unfortunately, those type of instances happen more in this patient population. And so screening for anxiety, depression is really important. And also making sure you're screening for tobacco use at every visit and supporting people if they're willing to try to cut back. Screening for unhealthy alcohol use and regularly screening for IV drug use. And for those that do use IV recreational drugs, that counsel on safer injection sites really have uh, uh, try to have some information on safe practices and regular screening for viral hepatitis and other infections that are more common with IV drug use, talking to patients about pre-exposure prophylaxis and post-exposure treatment for injection partners, and info and always think about if there is information on like syringe services for harm reduction if possible. And then definitely if you think someone's at risk for real quick, Alex, if someone's at risk for uh, um, IV for opioid use, please provide naloxone. Yeah, Alex.
No, I think that's a very important comment with the fentanyl crisis ongoing. I would also put in a plug for Suboxone.
Yeah.
Any prescriber can write that. There's no more X waiver. It finally went in the trash can of history where it belongs. And if you're not a provider, if you have a connection to people who are comfortable and trained in Suboxone, try to have a referral network so that if someone does mention, "Hey, yeah, I would like some help," have a plan in place of where you can get them. Because if you talk to people who have gotten into recovery, they'll say that like that one person who cared, like one testifier at a recent bill about syringes, I said, if I would have interacted with somebody who gave a damn, like I might have, gotten out of this years earlier. And I have a lot of friends who didn't make it out. There's a lot of literature and expert opinion that primary care, addiction specialists, and infectious disease specialists, we all need to be part of the solution to that. I mean, really everybody in medicine does, but in particular here. So if you're not knowledgeable about Suboxone, I'd be happy to help facilitate connections. There's that other echo. I mean, it's another thing that is very important, especially when people have multiple levels of stigma and barriers. So thanks for bringing that up, Spencer.
Yeah, I agree with. I mean, it's a really good point because I was uncomfortable with Suboxone for a while until I started doing it more and talking to individuals that just helped educate me. And it really, once I felt more comfortable, I feel like, unfortunately, there's still a lot of providers who are uncomfortable with it, and that's you. That's okay. Reach out and ask questions. But you really can make a huge difference in patients' lives, and it's just meeting them where they're at and letting them know that there are options that can be really helpful. And now I've been able to have some really cool interactions with patients that their lives look very different, and it's quite rewarding. So yeah, again, always asking about childbearing potential and plans, just so that patients can kind of understand, so that we can help educate on how to prepare for that and what to expect. And always talking about adherence education to maximize personal health and reduce transmission. That undetectable means untransmissible, and really educating patients on that and letting them know that you know what we're able the care that we're able to provide from a primary care standpoint and from an HIV therapy standpoint can really provide the ability for them to lead really full and fulfilling lives. And I think that really helps with that education really helps with engagement. Optimizing sexual health, and I won't go into this here. We already had to talk about this, but definitely being knowledgeable about pre-exposure prophylaxis, excuse me, and post-exposure prophylaxis, and being able to support patients that would benefit from that and that are willing. Barrier protection, other strategies to reduce STI transmission. And then, of course, an oral health exam every 6 to 12 months. My dentist father-in-law would be quite upset if I didn't mention that. But everyone should have regular oral health exams. Um, Immunization considerations. This is kind of something where I go back to that checklist, and just looking at the guidelines is nice to just check off it like, oh, what's this? I will go back and check myself so many times. But I think it's really important to say that there is some extra things to consider on here. That inactive vaccines are always safe. Live vaccines are okay as long as the CD4 count is over 200. But there are a lot of vaccine considerations that definitely in patients living with HIV, really important. Everyone gets pneumococcal, influenza, COVID tetanus, diphtheria, H. pertussis, and meningococcus by standard guidelines. Um, uh, Now, for hepatitis A and hepatitis B, something that you should be screening all patients for and revaccinating for. Some more information there on kind of how to um, uh, do that more specifically, but also just that there's regular screening for those and revaccination. The MMR vaccine. So for right now, what I've been doing is it's very reasonable to check for immunity in all patients and revaccinate if needed. This may be changing with there's been some with the outbreaks now in 7 or 9 states. Just be on the lookout for potentially new guidelines depending on where you're practicing. But something to keep in mind. The HPV vaccine is something I offer to all my patients up to age 45, a 3-dose series once they're past age 15. And so that's something I bring up to a lot of patients. And then the shingles vaccine, specifically the RZV, the 2-dose series for anyone over 18 that's living with HIV is something to keep in mind. Um, Mpox, if you're not familiar with Mpox and vaccination for that, just knowing that um, there is the 2-dose series that's 4 weeks apart is something that several people, depending on their risk factors, may be indicated for. So just making sure you've read up on that. And then the respiratory syncytial virus vaccine, um, pretty much for standard guidelines for anyone over age 75 and then 65 to 74 with risk factors. And it's just a 1-dose vaccine. Um, that's so I went through immunizations pretty quickly, and but that's something that I'll go back and check on multiple times. It's just kind of a check the box type thing, but important nonetheless. In terms of cancer screening, I think two of the bigger things that I wanted to talk about was just that cervical cancer screening is different. It's kind of confusing. I tried to summarize it here. I hope this uh, seems or comes off okay. But for those that need cervical cancer screening, for 21 to 30-year olds, you can do 3 consecutive normals and then move to every 3 years. And for anyone over 30 years old, you do it every year until there's 3 normal without HPV, and then you can do every 3 years. And if there's just 1 normal with a negative HPV, then you can start going to every 3 years after that. So, and there's no age limit. You can continue screening past age 65, um, depending on a discussion about life expectancy and kind of patient wishes. But anal cancer screening. So right now, for anyone over 35, if there's any anal penetrative intercourse specifically that talks about trans women or trans feminine individuals that were assigned male at birth and men have sex with men is how the guidelines are written. But personally, I think that just having an open conversation with patients about their sex lives and if they're at higher risk, consider screening. But definitely over 45 years old, for anyone living with HIV, you can do anal cancer screening. Consider oncogenic cancers such as HPV, hepatitis C and B, and just know that um, those are things to keep in mind when you're taking care of patients. Um, and then just know that prostate cancer screening, breast cancer screening, lung cancer, and colon cancer, you can all do they should do screening as indicated by standard guidelines. There's nothing new or really different for patients living with HIV. Um, and I'll talk about gender diverse patients briefly later as well when it comes to screening. Um, Hepatocellular carcinoma screening for anyone with cirrhosis or chronic hepatitis B or C, hepatitis C specifically with more advanced fibrosis. And then again, talked about this earlier, but screening for regularly for tobacco use, alcohol use, and then really thinking about vaccinating against HPV and HBV. So just keeping in mind that these cancers as well as other metabolic issues happen more often in patients living with HIV and at younger ages. So just kind of being vigilant. So, cancer screening for gender diverse patients. I think that first I will say is be empathetic, understand that this can be a very sensitive and triggering exam for some patients, and that you want to bring it up as just a normal part of care, but also understand that patients may be quite hesitant. And I think that there's a lot of stigma that patients have often felt very acutely in the gender diverse community, and I think that has a lot of parallels to a lot of the stories that Dr. Dworak was sharing earlier about patients living with HIV now and in the past. And I think just having um, that general thought process in mind when we're trying to connect with patients and get them engaged in care, just to remember that perspective and that point of view. But when it comes to gender diverse patients, really asking, frankly, if you have any questions, if they were assigned male or female at birth, and doing, at some point over time, and I don't have time to go into it right now, but kind of an organ inventory. Any organ that they have in their body that needs to be screened for cancer should be screened. If a patient has a prostate, then you should discuss prostate cancer screening with them at the appropriate time. So for someone who's assigned male at birth but has undergone a vaginoplasty, the prostate is not removed, and so you have to talk about prostate cancer screening. The PSA is often not reliable for patients that have been on androgen blockade for quite some time, or already had an orchiectomy or removal of the testicles. So remembering that. Um, and that a digital rectal exam or a digital rectal and neovaginal prostate exam should be used to just to should be offered for screening. For patients assigned male birth on feminizing hormone replacement therapy, after 5 years of feminizing therapy, depending on their age, if they're over 40, you should discuss breast cancer screening with them. And also for patients assigned male at birth, please don't forget about the prostate. Um, for patients assigned female at birth, again, I've been part of what I've done gender affirming care as a large part of my career over the last 8 or 9 years now. And a lot of patients assigned female at birth that are on masculinizing hormones are more than reticent to bring up and talk about cervical cancer screening, but just saying like, hey, this is a normal part of medical care. And I know that it can be uncomfortable. The procedure can be very uncomfortable. Just thinking about it can be uncomfortable, but it is something we should talk about. And I should just, being willing to have that education about the fact that it's needed, and that it should be offered. Um, so STI screening for anyone sexually active, gonorrhea, chlamydia, and syphilis, and trichomonas for anyone that engages in receptive vaginal sex should be offered every year. And then one thing I think is really important to remember is that gonorrhea and chlamydia testing by nucleic acid amplification testing should be site specific. And so for me, I've always said like I'm going to be very blunt and ask you some questions. You can answer whatever you're comfortable with, but I always ask, what their sexual practices are like. And I say like before you answer, the reason I ask is because if your mouth or your anus or your vagina or neovagina, anything that's involved should be screened separately. And so those things are those what this is why I ask those questions. I know it sounds very invasive. So I always put it like that. And most people are like, oh no, I understand. I do think I would like oral or anal swabs or whatever the case may be. Consider self swabs because there can be good education done, and they've studied this, and that swabs can be very useful in screening and really increase acceptance and comfort for the patient. So just something to think about there. Um, and then for patients with recurrent urethritis or cervicitis, and in pelvic inflammatory disease, consider screening for Mycoplasma genitalium. And then TB screening for everyone once diagnosed, and also consider yearly screening. I know it's under STI, but just wanted to put this in somewhere. Consider yearly screening in those that are at increased risk. And if you look at the guidelines, they give you some bullet points there about things that would put someone at increased risk potentially. Um, When it comes to mpox, something I wanted to mention was that, monitor for symptoms for 21 days. If you think anyone's been exposed, if you have information that there is a kind of an active outbreak in your community, but that you can consider vaccination for asymptomatic individuals within 14 days of exposure is something to remember. And there's some other things there about screening and potential treatment, but I'm know I'm getting late on time, so there's a couple things that I wanted to get to. Discuss with patients doxycycline for post-exposure prophylaxis in those that qualify. One more time, I've already said that before. One of the things I really did want to get to was cardiovascular and metabolic disease, and make sure I had a few minutes to talk about this. That for cardiovascular disease, HIV itself increases the risk, and that, and certain medications, but people living with HIV have higher rates of weight gain, hypertension, hyperlipidemia, hyperglycemia, and glucose intolerance. And so the big point here is to be vigilant and to continue to screen for things and provide, good primary care like we should be doing. Um, and I'll try to talk about each one of these things. But definitely, I mentioned it earlier about screening for tobacco use and being comfortable with offering nicotine replacement or other interventions to try to help people quit when and if they are ready to quit. Um, that, lipids, I think are regularly screening for hypercholesterolemia and hyperlipidemia is really important. A fasting or random in the guidelines is stated as being fine just to get people to get them. And if they are abnormal random, considering a fasting to see exactly where things are and to more accurately calculate an ASCVD risk and have a discussion about intervention. But prior to and within 1 to 3 months of starting antiretroviral therapy, assessing ASCVD risk and understand that in patients living with HIV on antiretroviral therapy, it's a strong recommendation for anyone with an ASCVD risk greater than 5% to consider a moderate intensity statin. So a little bit different than other guidelines. Just being really comfortable with statin therapy. There are a lot of those in patients living with HIV that very likely would benefit. And that there's really no place for low intensity statins. If you're going to consider statin therapy, it's considered that you work up to or even start with a moderate dose. Um, when it comes to screening for glucose intolerance, prediabetes, and diabetes, random or fasting blood sugar is the key here. You can get an A1C, but know that it is insensitive and it may underestimate their risk of diabetes mellitus. So, if it is if it is greater than 6.5, then yes, it's very likely if you have multiple A1Cs greater than 6.5%, then you can make the diagnosis of diabetes. But if it's less than that, really consider following fasting glucoses to more accurately reflect their risk. And then with that, talking about weight and weight gain being more common in patients living with HIV, that really being comfortable with counseling on diet and exercise, alcohol use, sleep, all the things that we know can help promote a safe, healthy lifestyle and weight loss. There's no current data to switch antiretrovirals solely based on weight gain. But before I get to the next slide, I have in my own practice started working on for those at the highest risk with maybe very high BMIs and multiple comorbidities, considering medications, although it's very difficult to get a lot of medications covered for weight loss. But I consider those more strongly in this population in some instances, just because of the for patients at high risk that have a lot of cardiometabolic issues, it really may benefit them more so than others over the long term. For pre-med, I think I'm getting really close to time. Yep. So for metabolic disease, understand that if you do have LFT increases, that there's some guidelines around imaging, looking for steatosis, and then even following up and looking for fibrosis. So there is some guidelines on maybe some more advanced things when dealing with LFT issues, and if you think someone does have steatosis. And that again, weight loss and something is part of treating that. And so there's just a lot of these cardiometabolic issues that start to build on one another and are more common in this population. Premature bone loss that we start DEXA scan starting at age 50 for anyone assigned male at birth, or postmenopausally for anyone assigned female at birth. Um, I just wanted to note that chronic lung disease is more COPD, lung cancer, pulmonary hypertension, and fibrosis is more common in patients living with HIV. So just being vigilant about that when people have or developing lung issues that you're taking care of. And then I did want to make a comment that and I don't think there's necessarily anything specific in the guidelines, but common infections versus opportunistic infections. We had a case recently where someone arguably didn't receive the most optimal care they could have because the provider's mind jumped straight to opportunistic infections when this patient had been very well treated, virally suppressed. And the opportunistic infection should have been probably quite a bit lower on the differential, but that, in a lot of cases for someone that's really well treated, consider more common infections first on your differential rather than opportunistic infections. Um, there's a couple other things here. Pregnancy in patients living with HIV. And again, we'll send these slides out, so hopefully you'll be able to look at these more closely, but also some specific things on breast and chest feeding for persons with HIV and how we can support our patients with that. And we've talked about this before, but gender affirming care and respect for those in the gender diverse community is a big part of engagement and appropriate healthcare. And we see that a lot in caring for patients that are living with HIV and in those not living with HIV. So helps a lot in providing the primary care we do. So with that, that's all I had. I know we only have a few more minutes, but Alex, I didn't know if you wanted to say anything else.
Sure. Again, we're happy to take questions. I'm keeping an eye on the chat. There are some great ideas and discussion there. I included a little bit more information about Black Americans living with HIV. And again, just my patient sadly embodied that very literally. And again, just hugely disparate rates. And again, there's nothing about HIV and nothing about Black people or transgender people that makes that mandatory. That is a function of social factors. And again, I appreciate all of you being here, the work you're already doing, wanting to learn more, because disparities, in my mind, cry out to be fixed. And as we were talking with primary care, the goal is to let everybody be healthy, to live their full and authentic lives, to do what they're meant to do in this life. And when you see disparities, you know that some people aren't getting a level playing field and having that chance. So, but I think there might be one more slide after that, Spencer, if I remember what I threw together. But yeah, just again, and for me, it's really important that I appreciate being able to tell my patient's story and remember her. I'm glad I was able to help her while I could. Uh, and I want to continue working to make a world where her story isn't that predictable. So. And again, there are a lot of data that Spencer has presented. Again, he has his resources here that you can refer back to. This is too much for me to remember off the top of my head, but again, with some of these references here, just to help people live well, provide them good, personalized care, and that goes for people who don't have HIV, people who aren't queer, people who aren't of color. Like all of us have all of us have things that make us unique, and the same approach of like just be good to everybody. I think which hopefully isn't a surprise for those of us in medicine, is always good advice. Uh, Dr. Fadul, would you like to go ahead and jump in here?
Yes, thank you so much, Dr. Dworak and Dr. Kenzie, for the presentation. This was excellent. And I know sometimes this information seems like it's overwhelming, it's a lot, but one of the things we wanted to emphasize in this echo is that this is kind of a cumulative process so that we will have more sessions addressing these things, more cases down the line. And we're here, all of us, our team, Dr. Kinsey, Dr. Dworak. If you come across a case that you have a primary care issue about, feel free to reach out to us. You have Heather's contact, you have most of our contact. So please don't hesitate if you have a patient with HIV in the clinic, or patients you want to test for HIV or you tested for HIV and you're not sure how to interpret the results. Our team is always available to answer those questions, and we have been doing that for a while. So we just want to emphasize that through you to spread that word back to your teams that if anything comes up and you're not sure, we always appreciate when primary care providers reach out to us about medications, especially if they want to add a new medication and they want to check to make sure there's no interaction with antiretroviral therapy. That's always a question that we appreciate because we make things sure from our side that the patient treatment is not impacted by new medications or additions. So thank you so much. This was excellent.